Hi doctors, how are you? Welcome to week number 4, where we are going to discuss about local anesthesia. After 3 weeks of studying pharma, this is too much. Let's move around from this one. Let's go to topic which is, we can call high yield topic with a lot of misconception, a lot of wrong numbers, not updated numbers, and a lot of confusion between us as a dentist. And you feel like, do I need a calculator in the exam? The calculation is difficult. How I can manage this? How I can manage that? Today, I'm going to share with you the solid knowledge. We are going to use the Malamud Handbook of LA to be our reference, and this is the reference for NDEB. And please, if you see conflict in number, check which reference and which edition, because there's edition number 7. This is the, we can say, the most recent one with the updated number, because I will show you now numbers and feel like, oh, I know some different numbers. I cannot blame you. Verify the source of the information. Make sure you go to the textbook itself, read it. Trust me, when you are in confusion and you hear a lot of this and that about a specific topic, the easiest way is to go to textbook. Or you can message me. I will do this third part for you, share with you the final result. Let's start with our 5 questions. First one. A 70 kilogram healthy adult is scheduled for multiple extractions. What is the maximum number of cartilage, 1.8 each, of 2% lidocaine with 1 to 100 epinephrine that can be safely administered? 7, 10, 13, 18. Okay, most of us being a dentist, because we hate calculation, we would just hear the calculation and we start to freak out. So let's try to break it down to understand what's happening here. So we need to understand 2 major factors. The first factor is maximum dose or recommended dose per kilogram. So as you can see, we have the numbers here. This is like articaine and lidocaine have 7, and we have mivicaine 6.6, prilocaine 8, and we have for bupivacaine 2, which is not written here. This is the maximum per kilogram, and then you need to multiply this number by the kilogram of your patient, and then it will give you the maximum amount of LA. But the question is asking about how many carbules. So you need to understand how much of this LA solution is inside the carbule. So we have 2%, 3%, and we have 4% and 0.5%. As we agreed over, the carbule is 1.8. So 1.8, 1% of 1.8 is 18. To make it easier for you, 1.1% of 1.8 is 18. When you go to 2%, multiply by 2, 36. 3 multiply by 3, 54. 4 multiply by 4, 72. 0.5 divide by 2 become 2 as a 9. So this is the major number. So we need to multiply the kilogram per recommended dose, 70, multiplied by 7, to give us 490. And this number is going to be divided over the amount which is available in each carpule. So let's go back here. This is 1 to 100, 2%. So 2% is going to be here, so 36. So you need to divide this number over 36 to give you the number. The number will become as 13, which sadly is not correct. I know, this is annoying. So let's give you the tables, because these tables will give you the number for all the calculation you need to have, you need to know, and you might be asked about. And again, this is from Malamud, so I didn't write it myself. So as you can see here, this is lidocaine 1 to 100, this is 50, lidocaine 2%, 1 to 100,000. This is what we are looking for. Look with me here, 70 kilogram, 11. Oh, why? 60, 11. So starting from 60 till the end, giving you 11. Although the number is going to be high, because 420, which is less than the maximum dose, because maximum dose is 500. So 420 is equivalent to 13. So why the final answer is 11? Look at this mark and read here. 200 microgram of epinephrine is the dose limiting factor. 1 to 100 contain 18 microgram per cartridge. So this is the cutoff, and this is the number where we are going to avoid. This is the number was going to be our maximum for the kid, for the adult, for anyone. So again, I know slightly confusing, but try to just go through it easy. So we have 2 calculations, one for LA itself, which we have the maximum recommended dose, as you can have from here. This is 500, and we have per kilogram, which is 7. When you make the calculation, 490 divided by 36, which is equivalent to the amount in each carpule, number will be around 13. But as you can see here, after the 50, he go to have the ceiling at 11. Why? Because of the amount of epinephrine, 200 microgram, which is 18. So 18 multiplied by 11, it will be so close to 200. This is why we do not exceed these 200. and here is the other number. So here the cutoff or the determining factor is the LA itself. Here, as you can see, the sign is related to the epinephrine. And I share with you the other. So mevicaine 3%, mevicaine 2% with vasoconstrictor, and prilocaine and articaine. If you would like to download this PDF, just let me know and in the comments, and then I can send you a link where you can download this PDF. And trust me, just knowledge about this information will give you a peace of mind, because I know for reality, most of us are very afraid of the LA calculation, and when you read it, we freak out. Please don't freak out. This is the easy way to memorize. I'm not asking you to memorize. I will ask you to understand it. Go with this number here. These are the most important number. And as you go, you can solve it. And if you would like to know the number just by the numbers, it's in here. Okay, so the answer here will be 10 cartridge of LA. Next question. An infected tissue with low pH, local anesthetics are less effective because, why? So he's stating a fact here that when you give freezing LA, an acidic medium, patient has inflammation in this area with acidic medium, it's not working, it's less effective. Why? More drug become ionized and cannot cross the nerve membrane. The drug binds more strongly to the plasma protein. Vasodilation increase systemic absorption. Sodium channel become resistant to blockage. Okay. Let's first understand what's happening inside the nerve. So inside the nerve, we have resting potential. And resting potential, this is -70. Nice. Once you receive like a signal, the signal will end up by slight drop in the number to become around -50 or -40. At around this number, this we call what we call action potential. When the nerve reaches this -40, -50, what's going to happen? The sodium channel is going to be open. The sodium channel is going to be open, and the sodium will run inside the nerve, which is going to happen to be depolarization, and then happen after that repolarization. Look here, what is responsible for blocking that channel? It is RNH positive. What's the meaning of that? So when you give any solution inside, like we give LA inside the soft tissue, inside the human body. Okay, so we have pKa, which is the constant dissolution of this solution, the LA, and we have the pH of the body itself. The closer this number to each other, the better the dissolution will happen. So let's give it number. If it's neutral pH, so this RNAH is going to be equivalent to RN, because there is no abundance of H, which is acidic medium. Think about it the other way around it. If you have acidic medium with a lot of H, and this H reflected by the drop in the pH is becoming low, so we are going to shift the balance toward this one. Okay, what's wrong with this? So we have this one to be responsible for blockage the channel. Cannot you see the picture? 100%, this is correct. But in reality, the definition is slightly different. So what's happening? In reality, the RN is the one responsible to penetrate inside the nerve, and it become like positive inside the nerve itself to become as this form to act to block the channels. So again, the non-ionized form is the one responsible for penetration to go inside the nerve. Inside the nerve, it become ionized to have this H. So when it have the H inside the nerve itself, is going to block that channel. So non-ionized for penetration, ionized for effective, for like this, like to be working. So we call this cation, and we call this base ionized, whatever you are going to call it. But the problem here in this question, we have acidic medium. So what's going to happen here? So local anesthetic are weak bases that exist in equilibrium between unionized form, which is Rn, and ionized form, which is RNH. Unionized, it's lipid soluble. Lipid soluble easy to penetrate, cross the nerve membrane. Cross nerve membrane, fine. When it cross nerve membrane, it become ionized inside the nerve to become RNH positive, which is water soluble, and this is the active form that bind to sodium channel. In this normal situation, when we have 7.4, which is around the normal pH, allows sufficient unionized space to penetrate the nerve membrane. After crossing, the drug reionized and block the voltage-gated sodium channel, preventing depolarization. So this is in normal situation. Let's see the situation we have in the question. Infected tissue has acidic pH, low pH due to inflammation, accumulation of acidic metabolic byproduct, and tissue hyperperfusion. This low pH shift equilibrium toward ionized So we are not going to end up by Rn and RNH. So we have more of RNH, which is water soluble, which is cannot penetrate. So what we are going to end up, less ionized, unionized drug available, cannot cross lipid nerve membrane, and reduce anesthetic effect. This explains failed anesthesia in the abscess teeth. And this is like a way to think about it. So this is the pH, this is the RNH, this is the RN. As you can see, the RN is the one crossing, become ionized, and this one is blocking the channel, preventing the sodium to flux and preventing the equation to start from the beginning. As you can look here, this is the pKa, which is the number of the solution where we have to have 50% ionized, 50% unionized. In pinky wallet, this is the one we love. In pinky wallet, this is the one we are looking for. As you can see, lidocaine, prilocaine, mevicaine, this articaine 7.8, and we know the normal in our body is around 7.4. So 7.4, 7.7, fine. But as you are going to have severe drop in pH to become a 3 or 2 or 4, which is related to acidic medium, related to inflammation, related to pus, at this point, no, it's not going to be abundant of ionized to cross the membrane, so the freezing will not work for your patient. Okay, protein binding, this affect duration, not the membrane penetration, not related to the pH effect. Vasodilation, again, this is for duration, not the reason for failure. Sodium channel resistance, this is nothing like this. Sodium channel remains sensitive. Problem is drug penetration. Okay, and this is related to the concept of pH and pKa. Next question. A 6-year-old child received topical benzocaine before injection. Shortly after, the lips appear cyanotic and the child became fatigued. Pulse oximetry showed 85% despite oxygen administration. So we have a mystery here. So you have a child who did receive topical anesthesia, benzocaine. And just to make it easy for you. So in LA, we have two families, amide, ester. Amide and ester. As you can hear it, amide has one eye, ester has no eye. If you see in the name of the freezing itself, one eye, so this is ester. If you see two eye, this is amide. If you see two eye, this is amide. If you see one eye, this is ester. So what family does benzocaine belong to? I think this is easy now. Okay, so you give him benzocaine as a topical. Shortly after, the lip appears cyanotic and the child becomes fatigued. And you try to give him oxygen. You try to give him oxygen, but although you are giving him oxygen, you end up by the oximetry, which is measuring the oxygen in the bloodstream, showing you 85. The normal is around 80, 94 and above. 95, 96. This is the normal. This is what we are aiming for. So what do you think the patient is having here? Anaphylaxis, acute asthmatic attack, mid-hemoglobinemia, or vasovagal syncope. So this is classic signs and symptoms of mid-hemoglobinemia. So what's happening here? Benzocaine is a non-oxidizing agent that can induce mid-hemoglobinemia, particularly in its children. So inside our bloodstream, the hemoglobin itself, it has the ferrous, which is Fe, which is stand for the iron, plus 2, okay, which bind to oxygen normally. So inside our hemoglobin, we have this one, which is fine. If this ferrous become oxidized to be Fe plus 3, which is ferric, this ferric form mid-hemoglobin, which cannot bind to oxygen. So the patient cyanotic, I'm trying to help him by giving him oxygen, but oxygen is not working. How I know it's not working? Because the saturation inside the bloodstream is not that effective. So what's happened here? This happened due to this mid-hemoglobinemia happened for the patient. His hemoglobin come from ferrous to become ferric, and ferric is not having that enough affinity to bind to oxygen normally. So what's going to happen for this patient? So what is the causes for this? Sometimes congenital enzyme deficiency, sometimes drug, benzocaine, disbone and nitroglycerin, and sometimes toxic due to nitrates. The symptoms, you can see the patient to be cyanotic, become as a blue, dyspnea, fatigue, and headache because no oxygen going to his brain. How you can diagnose it? You can look at the blood. When you take the blood from the patient vessels, you can see it's coming brown. Why is coming brown? Because when you look here, the ferric is becoming to be a brown in color. It's becoming to be brown in color. And this patient will have pulse oximetry, co-oximetry to be low. As you can see, 87. What is the treatment? Please listen carefully. What is the treatment? The treatment is not IV oxygen support only. It was going to be IV methylene blue. IV methylene blue, because this methylene blue going inside your bloodstream is going to chelate this ferric to be ferrous. Chelate this ferric to be ferrous. So it's going to convert this Fe+3 to be Fe+2, which bind to oxygen normally. And for sure, I'm going to give him oxygen to reverse the hypoxia happening for the patient. So the key diagnostic clue here, pulse oximetry reading remain around 85 despite I'm giving him oxygen. This occurs because standard pulse oximeter cannot distinguish methemoglobin probably. So the PA of O2, which is oxygen, and APG may appear normal. Blood may appear chocolate brown. So this is the problem having with the patient, and the treatment will be IV methylene blue. Let's see the other option, anaphylaxis. Anaphylaxis, it should be urticaria, hypotension, bronchospasm. These are the two keywords. To pick anaphylaxis or type 1 hypersensitivity, you should have these two plus anything else. Hypotension, severe drop in the blood pressure, bronchospasm. So the patient cannot take his breath. He's having this wheezing effect. And why is not correct? No hives, no airway edema, no hypertension for the patient. Acute asthmatic attack, wheezing, bronchospasm. Okay, you just said wheezing for the anaphylaxis. Yes, wheezing in asthma, it comes without hypotension. Usually it comes with hypertension. Not hypertension, like increase in the blood pressure. Let's say it in an accurate way, increase in the blood pressure, because acute asthmatic attack, as the name implies, acute, is acute, happen suddenly, and that's due to stress or due to oxygen deprivation or due to patient is like having this exercise-induced asthma attack. Here, we don't have respiratory stress in the question. And the answer is methemoglobinemia. Finally, vasovagal syncope. This is bradycardia, hypotension, and pallor. Cyanosis not typical here. And the CO2 is, oxygen is normal, which is not in this question. So the answer here is methemoglobinemia. Question number 4. A mandibular block is administered successfully, but the patient complains of persistent paresthesia of the lower lip 3 weeks later. Which local anesthetic is most commonly associated with this complication? Lidocaine, mepivacaine, orticaine, prilocaine. This is a very common concept, and it's discussed in details in the Malamed Handbook Local Anesthesia chapters, edition 7. He explained in epidemiology terminology. So how we do it in Canada. So you give the freezing for the patient, and then you write in the notes, this is the type of freezing you give to the patient, how many carb use, the technique you use to giving the patient the freezing. Okay, patient came after 4 weeks, after 6 weeks, after 1 month, after 2 months, and he's telling you have paresthesia here. So he did it the reverse way. He did go to all the patient with this complaint and going back to the chart, going back to the notes to understand what type of freezing is used for this patient. And they found the orticaine to be prevalent. The orticaine to be prevalent. Just out of curiosity, I would like anyone to answer this question. So this study Dr. Malamed did, how you can call it? This study, you go back in the history and to check the notes, to check the type of freezing, to correlate between this one and the complaint the patient is suffering from now. I hope someone will tell me in the answer. So they found orticaine 4% has been most frequently associated with prolonged paresthesia following inferior avar nerve block. Why? So what's going to be discussed now is speculation. No one knows for sure, but this is the finding. So why this happened, we can speculate now. Orticaine 4% concentration, amide anesthetic, have higher concentration, 4%, potentially greater neurotoxicity risk. The inferior avar nerve is particularly vulnerable. Why? Because inferior avar, you are going to penetrate a lot of soft tissue, going inside the, touch the bone, very close to the nerve trunk, very close to the nerve trunk. Needed trauma during block, high local anesthetic concentration exposure because of this 4% of orticaine. Paresthesia may result from direct needle trauma or intranuclear hematoma or chemical neurotoxicity. So this is the nerve. This is a different topic, but just to understand the concept. So the nerve ends up by paresthesia due to either you touch it or you have like a swelling, which is hematoma close to it, or you end up by a toxicity of this strong anesthesia to be very close to the nerve. And these three has names: neuropraxia, anastomosis, and neurotomosis. You should understand the difference between three and which one is having better prognosis. This is very important. Maybe we can discuss this topic in different question when we go about surgery. Epidemiological data show disproportionate reporting of paresthesia cases with 4% orticaine and the second one will be 4% prilocaine. So articaine and prilocaine most commonly related or correlated with this paresthesia for the patient. Lidocaine and mevicaine and prilocaine, yes, also reported, but this less number. So articaine is the most commonly ending up by this. So again, no one did give the patient articaine and waiting for paresthesia to happen. No, the patient was paresthesia, we follow back in the history what's happening, and we did this correlation. I hope now you understand the type of the study. Question number 5 and last question for today. A patient with severe cardiovascular disease required a dental extraction. Which of the following is the maximum recommended epinephrine dose for this patient? 0.04, 0.1 milligram, 0.2 milligram, 0.4 milligram. So not all the calculation question in AFK is like asking about how many carb. Sometimes the question is this. Sometimes the question asking you for articaine, what is the allowable or permissible dose per kilogram? What is the maximum safe dose? So don't think every time it will be so difficult question. Sometimes it's like a giveaway question. So here the answer is going to be 0.04 milligram. Why? Let's see why. So they did a study and they found when you give the patient who have hypertension, we discussed now about patient who has hypertension, patient with angina, patient congestive heart failure, patient with CVA, patient with history of MI. So this is the whole story about cardiac condition. They did this study and they found once with 5.4 milliliter of solution, which equivalent to 3 cartilage of 1 to 100. Let's see now the equation here. When this happened, you give your patient 3 with 5.4 milliliter, you end up by plasma level increase 5 to 6 fold. These changes were accompanied by significant increase in heart rate and systolic blood pressure, but with no adverse symptoms or sequelae. So if you give your patient 3, he will not be dead on your chair, but like you have subjected this patient to a huge increase in his blood level of epinephrine, and this will end up by significant increase in heart rate and the blood pressure. So they did meta-analysis of several clinical studies, determined that the mean resting venous plasma epinephrine concentration is 39, which is approximately doubled by the intraoral injection of single cartilage of 1 to 100. Okay, let's make it easier and easier. Here is the number. So this is the rationale about the number, and this is the number. So as you can see, again, from the same textbook for LA, it's called coming from the Mnemonics handbook. In normal patient, 1 to 50, 5.5, 1 to 100, which is the most common, 11. I hope you still remember why 11, not 13. For 1 to 200 is going to be 22. For cardiovascular disease, as you can see, 1 to 51, 1 to 102, 1 to 204. How? Because as we said, the 1 to 100 has 18. 18 multiplied by 2 will be 36, which is very close to 0.4. Amazing. So this is why we aim for this. And 200 will be 4. Again, different way to explain about it. 1 to 50 has 36, 1 to 100, 18, 1 to 200, 9. So epinephrine concentration expressed as ratio and need to convert to milligram per milliliter. So we need to convert the ratio to 1%, 1 to 100,000. So we need to multiply it, and then it's going to end up by this amount. So in each carbule of 1%, 1 milligram per milliliter, but the carbule itself is 1.8. So you're going to end up by 1.8, which is equivalent to 18. Why? Because we're measuring in the microgram, not the milligram. Let's go back here. So Mnemonics handbook and the American Heart Association recommendation. For patients with significant cardiovascular disease, ASA 3 or 4, the maximum recommended epinephrine dose is 0.04 milligram. This is referred to as the cardiac dose of epinephrine. Why this limit? Because epinephrine, when it's given, it stimulates both beta and alpha. So when you stimulate everything, you increase the heart rate, increase myocardial contractility, end up by bronchodilation and vasoconstriction. So this is the one we care for, and this is the study was done, again written in this same textbook, just copy and paste of the information. So the answer for this one will be 0.04 milligram for the patient, which is equivalent to 1 of 1 to 50, 2 of 1 to 100, 4 of 1 to 200. Hopefully this small lecture give you idea about LA. LA is extremely important. This is your topic. You are the specialist about LA. No one else in the whole world can answer these questions. So please pay attention to this. Pay attention to number. There are more concepts. Maybe we can discuss those concepts in different quizzes, but like this is the most important topic you need to understand and the most important number you need to memorize about LA. See you next Sunday.